Swayam Prabha. Digital India. Educated India.
Hello and welcome to this lesson. Let us continue the journey of learning bacterial infections. In this lesson, we are going to discuss the lower respiratory tract infections. At the end of this lesson, you all will be able to understand what are lower respiratory tract infections, what are the bacteria causing such infections, and what is the approach to their laboratory diagnosis. What I thought the best way to deal with infections is to start and discuss it with a case history of a real patient. We are going to discuss it under the following headings: the lower respiratory tract infections including epidemiology, complications, definitions, etc., and also the bacteria causing and their detailed structural characteristics, the microbiological investigations or the lab diagnosis. We are going to deal this topic under these three headings and cover the contents. As I said, we had a case, Mr. Ashok, 55-year factory worker. He was a chronic smoker and diabetic. He suffered from common cold recently. 3 days later, he became quite critical. He developed high fever with shaking chills, and also he had productive cough which was rust colored, and he also had breathlessness along with the chest pain. Then he approached the doctor. On examination, the temperature was 104 degree Fahrenheit, respiratory rate was 40 per minute, and X-ray showed consolidation of upper lobe. The WBC count of this patient was quite high, with 1/3 of band forms seen in the peripheral smear. Now, what do you think this patient is suffering from? I think it is obvious that it is a lower respiratory tract infection and he is suffering from pneumonia, and the pneumonia we diagnose it here as a community acquired pneumonia because the patient was not hospitalized and he did not develop this infection within 2 to 3 days hospital admission. What is community acquired pneumonia? It is the inflammation of the lungs caused by microbes in which the alveoli are filled with either exudate or pus in a non-hospitalized patient. This infection is characterized by fever, chills, cough and difficulty in breathing, chest pain, all compromising and leading to the reduced lung function. Why did we diagnose this case as a community acquired pneumonia? Because onset was sudden, he was all right just 3 days prior, and it all occurred in a susceptible host because he was a chronic smoker, diabetic, and also his upper respiratory and lower respiratory tracts were compromised by prior viral infection, that is common cold. This resulted in a consolidation on X-ray what we observed, and also was supported by the leukocytosis in the laboratory investigations. That is why this case was diagnosed as a community acquired pneumonia. Let us see what are those bacteria causing community acquired pneumonia. The most important causative agent is the Streptococcus pneumoniae, the others being Staphylococcus aureus. It may be methicillin resistant Staphylococcus aureus which has also on the rise nowadays. Other causative agents being the Klebsiella pneumoniae, Haemophilus influenzae, Moraxella catarrhalis, and to add to this list, which are mainly included in the hospital acquired infections as well, are Mycoplasma pneumoniae, Chlamydia pneumoniae and others. There are few anaerobes which are also capable of causing pneumonias, especially if there are already the compromised lung as well as associated predisposing factors. The anaerobes which can cause such infections are Fusobacterium necrophorum, Prevotella melanogenica, Porphyromonas, and sometimes rarely the Bacteroides fragilis group as well. So, we have a battery of causative agents causing this condition. So, what we think now is just making the clinical diagnosis of community acquired pneumonia is not just sufficient, but we also need to confirm the diagnosis in the laboratory, because we need to find out the causative agent so that the specific and prompt therapy can be started at the earliest to prevent complications, help the patient recover faster. However, we could not wait in this patient because the patient was already critical and already the compromised lung function was set in. The physician started him on the empirical therapy with the penicillin. After this, we told him to collect the sample properly. The samples we suggested in this case was sputum, blood and the urine as well. What we stressed on in this, it is very important to have a good quality sputum. If the patient do not understand how to collect the sputum, there is going to be a problem. As the saying goes, garbage in, garbage out. If we receive a poor quality sputum, we are not going to isolate much, because we are not going to get the right specimen representing the disease site itself, that is deeper in the lungs. So, we stressed on the point that proper sample collection has to be done after educating the patient, and if the patient was not able to give the sputum on his own, then induced sputum collection could also be suggested. Blood collection was asked for and the urine as well. A proper sample was collected from this patient. Other sample in such cases which could be collected if the patient is not in a position to give such samples, which may happen in 50% of the cases who are very critical. In such cases, we can go for some of the invasive techniques, like as suggested here, the bronchoalveolar lavage. That can also be a possible sample which we could receive for laboratory diagnosis. Then what we said was, after collecting the sample, it should not be refrigerated, rather it should be sent immediately to the laboratory without any delay. We received the sample in the laboratory. Soon as we received the sample, gross examination of the specimen was done, because the history was suggestive of rust colored sputum, and that was very much evidenced on the gross examination. The next thing we immediately did was the microscopy and the gram staining. By doing microscopy, we are more interested to confirm the quality of the sputum. The quality of sputum is important, because if it was not collected properly, it would have less number of pus cells and more number of squamous epithelial cells, which are supposed to come directly from the saliva. And if the patient has not understood what is a sputum, then we receive some bad quality sputa. So, in this case, as we are seeing here, we are seeing plenty of the polymorphonuclear leukocytes per low power field, and we judge that this is a good quality specimen. As we are seeing here, the gram positive cocci, which are arranged in pairs, diplococci, and we also see a mild capsule surrounding these pairs. So, we saw something suggestive of Streptococcus pneumoniae. They were gram positive, approximately 1 micrometer in diameter, flame shaped cells, and they were having capsule. Then we also thought of going for the quelling test. This test can be done as a bedside test, wherein we take the sputum and we add specific capsular polysaccharide antiserum is added, plus a drop of methylene blue, and we subject the preparation under microscope. We see here the swelling of the capsule is more evident, and this is more confirmatory of Streptococcus pneumoniae. This was all being done immediately as we received the sample. Then within half an hour, we called the physician back and we said that we are seeing some of the organisms suggestive of Streptococcus pneumoniae. As all of us know that the Streptococcus pneumoniae can be a commensal in the throat, we could not really assure that they are the pathogens, but however, we asked him to continue the treatment, because the treatment was already started against the gram positive bacteria. To confirm further growing of the organisms, isolation, identification, culture and antibiotic sensitivity was very important in this case, as we had finished with these two tests already. And we went ahead on day 1, inoculation, selection of the media, inoculation on these culture media, and incubation under proper conditions if we suspected the aerobic organisms, at 37 degrees centigrade they were incubated. Otherwise, if anaerobes were suspected, we could incubate them in the Macintosh Fields jar. Selection of media is very important here, as we already have a clue from this sample that there are gram positive organisms. We chose a blood agar, and if it was anaerobic bacteria suspected, we could have chosen some Robertson Cook meat media or kanamycin vancomycin lake blood agar as well. And we also chose the McConkey agar because if there were some unseen gram negative bacteria, we could recover them. So, after choosing the media, they were inoculated and incubated for 18 hours. And as we remember that this case, we also asked for the blood sample. The blood culture was also incubated at 37 degrees centigrade. On the next day, we saw the colonies or the bacteria growing on the blood agar plate. They were typically alpha hemolytic colonies. As we see here, there is a zone of incomplete clearing of RBCs. This we call as the alpha hemolysis, and also the colonies were having a typical morphological characters, what we call as the Draftman colonies, which are also going to resemble the carom coin appearance. As we see here, the colonies, if you observe carefully, are having such a morphological features. After recording the colony characters, we went ahead. The blood culture bottles were also subcultured on blood agar. We could appreciate the similar colonies from blood as well from this patient, that is after 48 hours. Once we know that the organisms are gram positive organisms producing alpha hemolytic colonies, we went a step ahead and carried out certain biochemical reactions. The catalase test was done, which was negative. We remember that this is the most important test to differentiate the staphylococci and streptococci, as we are dealing with the gram positive cocci. So, this is the little more confirmatory now after doing catalase test that we are dealing with the streptococci. We also went ahead and did the bile solubility test. This is the broth culture to which 10% sodium deoxycholate is added, and after 3 hours we see that there is a clearing, the turbidity has now cleared out, and we are seeing this test, it is positive. Other biochemical tests what we did in this case are the inulin fermentation. We took his serum sugars and inoculated the bacteria, the colonies, suspected colonies, and we saw that the inulin was fermented, which is another characteristic of Streptococcus pneumoniae. After doing this, what is most important remaining in this workup is the antibiotic sensitivity testing. After 18 hours, we got the colonies, and the colonies were streaked on Muller-Hinton blood agar, and we subjected colonies against the first line and some of the second line drugs which are suggested for testing against Streptococcus pneumoniae by CLSI, and we saw the next day, that is on the third day morning, we saw that this bacterium which we were thinking of Streptococcus pneumoniae was found to be resistant to penicillin. We can see here the penicillin, it is resistant, and we now started thinking back about the patient what we had. He was already on penicillin group of drug for 2 days, and we were actually surprised to know that he may not be responding. So, immediately we called doctor and we said that it is the time to change the antibiotic to ceftriaxone. So, at this stage we have done with the direct methods for demonstration of this organism by getting all the results of culture, isolation and identification. We identified it as penicillin resistant Streptococcus pneumoniae, and the report was informed to the physician, and he changed the line of treatment to ceftriaxone IV. We know that the resistance of Streptococcus pneumoniae is alarmingly high recently, is mainly because of the mutations taking place in the penicillin binding protein in the cell wall, or it may be due to efflux mechanisms. These are the mechanisms of resistance in this organism. As we did the timely lab diagnosis, we could save our patient from various complications which would have resulted in this patient, especially the pleural effusion, empyema, which are very common. In 40% of the patient might end up with these complications, and in another 25% of the cases septicemia, in our case the patient was already in the septicemic phase, because we also recovered the organisms from the blood culture, and we also saved our patient from one of these major complications which would have been quite fatal. We have now learnt about the direct test. There are some indirect tests which are available. These are the antigen detection, toxigenicity test, PCR, biomarkers which are supportive tests like CRP, procalcitonin, etc., which are going to help us assess the prognosis. The other tests in this patient are antigen detection, which can be done directly from the sputum. Actually, the antigen detection is the detection of capsular polysaccharide antigen, which could be done from urine, CSF, and also from serum. The methods which are available to test this antigen are counter immunoelectrophoresis, latex agglutination, which is a popular one. Diagram shows here the latex agglutination test. Also, we could go for co-agglutination test for detecting the capsular polysaccharide antigen. And PCR, multiplex PCR, is especially done in Streptococcus pneumoniae infections, especially if it is a meningitis, because the load of organisms there would be very minimal, and the PCR multiplex will definitely help in diagnosing the Streptococcus pneumoniae organisms from the CSF samples. To confirm whether the isolate is a pathogenic one, there is a test which is available called as the mouse pathogenicity test, wherein the washed broth culture is inoculated intraperitoneally in the mouse, and within 48 hours the mouse dies, and we could recover and demonstrate organisms from the peritoneal fluid as well as from the cardiac blood. If this test is positive, it definitely indicates a toxigenic strain of Streptococcus pneumoniae. So, till now we have taken the example of a case, Mr. Ashok, and what went on with him and how we helped him recover faster, and we have also meantime learnt during the discussion of this case what is community acquired pneumonia, what are its complications, and also studied certain morphological features of this organism, cultural characteristics as well, and also some laboratory tests we have learnt in this case. We are left with certain points, that is the epidemiology, pathogenesis of infection, and the preventive measures what we can take. So, in this segment let us cover these points about community acquired pneumonia. Coming to the epidemiology of this infection, it is very common infection, rather Streptococcus pneumoniae pneumonia is quite common. Annually 120 to 156 million cases occur globally. The infection is mostly sporadic, but it can occur in epidemics if there are crowded condition, closed communities. Out of these 1.4 million deaths occur annually, and 95% of deaths are common in children, especially from the developing countries. What are the source of this infection? We know that the Streptococcus pneumoniae can be a normal commensal in a healthy person in the nasopharyngeal area, and the infection usually can occur from an exogenous source or from an endogenous source, or it is likely to come less often from a patient. Transmission occurs through aerosols, droplet and droplet nuclei, or from direct spread. Streptococcus pneumoniae, as I said, it not only causes pneumonia, it can also cause meningitis, otitis media, and sinusitis as well. It is common in people who are having certain predisposing factors, like if the patient is immunocompromised due to some reasons, or the patient is having malignancy, especially the head and neck malignancies, patients are more prone for going into pneumonia. If the patients are asplenic, it could be functional or anatomic deficiency. The patient may be suffering from chronic lung, cardiac, as well as the kidney disorders, some connective tissue disorders, and also the people with organ transplant. As the reason is obvious here, they are immunocompromised. Let us now see the pathogenesis of Streptococcus pneumoniae. We know that they reside in our nasopharynx and they have certain important virulence factors. The most important virulence factor in Streptococcus pneumoniae is the capsular polysaccharide. but other than that it has a lot more. Let us see how the pathogenesis takes place. As I said, the source could be external from a patient or from another carrier, or it could be the internal source. Once the organisms gain access into the deeper parts of the lungs, they start evading our normal immune mechanisms by secreting certain important factors. It has got some of the factors in its own cell wall, its capsule, but certain others it can secrete as well. Important one amongst them is the pneumolysin. The surface factors which will help it to cause the disease is the surface protein. This factor helps the organism to adhere to the epithelial cells of the respiratory tract, and once it gets attached, it is also going to secrete the IgA protease, because as a part of normal immune mechanism, the IgA is trying to trap this organism. The organism lies this IgA because it can secrete the protease. There are other factors come into play, ultimately resulting in the inflammation and fluid accumulation. The factors which are going to help in the pathogenesis of Streptococcus pneumoniae is the somatic C antigen, the pneumolysin, which is encouraging the release of interleukin, tumor necrosis factor, ultimately result into inflammatory process in the alveoli and exudate formation, fluid accumulation and compromised lung status. This is the pathogenesis of Streptococcus pneumoniae. It is also important to understand the physiological properties of Streptococcus pneumoniae, because this will help us to understand the pathogenesis well, as well as it will help us to choose certain important culture media when we want to grow this organism. We should know that these organisms are facultative anaerobes, they are fastidious organisms, in the sense they are exacting in their growth requirements. They either need serum, blood for their growth. They are specific about requirement of carbon dioxide. They are also called as the capnophilic organisms. They are catalase negative, alpha hemolytic, optochin sensitive, they are boil soluble and they ferment inulin, as we saw all these properties when we were carrying out the test when we are working up with the case of pneumonia. Coming to prevention of such infections, protection is mostly required for people who are at their extremes of age. We can use vaccine which is popularly called as Pneumovax, and it is available for injection. It can give 90% protection, and in an infected patient, if he is already vaccinated, it can also reduce the invasiveness of the organism and reduce the fatality. As I suggested, it is indicated in the extremes of age, people having chronic organ disorders and also immunocompromised status for any reason. Vaccines which are available, one of them is 23 valent polysaccharide vaccine. Capsular polysaccharide is the most important antigen, as I already said. The antigens have been characterized, and it is known to be existing in more than 90 serotypes. Therefore, it is little difficult to devise a vaccine containing all 90 different types. However, 23 important antigens have been included, so that it is going to give protection against the important serotypes which are going to exist in a particular country or the area. First one is more suggested for adults, the second one is the heptavalent, as the name itself indicates. 7 important serotypes which are supposed to be more common in children has been included in this vaccine. Other than vaccines, sometimes antibiotic prophylaxis may be needed in children who are suffering from sickle cell diseases. This is all about how we can protect from Streptococcus pneumoniae infections. Let me summarize what we learnt in this class. Streptococcus pneumoniae is the most common cause of community acquired pneumonia. They are fastidious organisms and they are gram positive with a typical lanceolate shaped capsulated organisms. Their resistance is on rise against the penicillins. Therefore, timely identification of such organisms in the laboratory, antibiotic sensitivity testing can add as a life saving measure for the patient. We also know that effective vaccines are available. I hope in this class we have covered the contents and we have met the objectives as stated in the beginning of this class. Thank you.